Good afternoon, everyone, and thank you for attending today's webinar, How to Respond to Document Requests, Audits, and Overpayment Demands, presented by Guillermo Beatis with Friar Levitt. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and A portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Guillermo.
Thank you, Bria. My name is Guillermo Beatis. I'm an attorney at Friar Levitt. I handle a lot of document requests, audits, overpayment demands, as part of our healthcare department. I'm here to talk to you today about some of the things that I'm seeing happening a lot, particularly trends of the last couple of years, some hot button areas, and I want to try to give you some practical advice on, one, how to insulate your practice, and two, how to respond in a way that is going to minimize any fallout. So, getting to investigations, they really are not all created equal. And I want to first start to give you a little bit of perspective as to how they're different in which ways. So first of all, you have to understand that, I read somewhere that next to, I think it was nuclear regulations, healthcare is probably like the second most regulated industry in the country. One of the reasons for that is because when the Office of Inspector General puts out reports with fraud analysis and their extrapolations on what they believe the type of fraud that you see in this country, where that fraud is, where that money is being diverted from our tax dollars, healthcare fraud is considered the largest by a multiple. The one thing that they focus in on the most in these investigations is fraud, waste, and abuse. You'll see a lot of OIG reports saying, the certain task force just busted, 70 different practices, across 4 or 5 states. They're being very, very active because they know that the problem is prevalent. In some cases, we have really bad actors. But in a lot of cases, unfortunately, you have people with good intentions, practices with good intentions, that are just doing something that they don't know is incorrect or that they think is correct because everyone around them is doing it, but then they learn quickly that everyone can be wrong. So I want to give you some advice today to try to keep you out of some of these areas where I'm getting a lot of clients, that come to me, they sit across the table from me and they're telling me, I know X amount of practices that do this same thing, or I came from another practice that was doing the same thing and they never had a problem. Well, I'm here to tell you that unfortunately that's not a defense. Ignorance of the law has never been a defense in this country, and I'm trying to educate you so that you can try to insulate your practice. Obviously, diversion and indiscriminate prescribing is one of the hot button areas across the country. It's such a epidemic that even both sides of the aisle in Washington actually agree on this. One of the very few bipartisan issues. So if you have a practice that has a lot of pain management or that prescribes a lot of opioids, a lot of Schedule II drugs, you really want to make sure that you have a strict opioid compliance plan, that you have all your prescription pads locked up, that you constantly check the PMP. You want to do as much proactively as possible to insulate yourself from any potential diversion or indiscriminate prescribing. Because what tends to happen a lot is that you'll have an investigator come to your office, and then they will have pretty much a broad investigatory scope, and everything that they see, they can't unsee it. So they have to then investigate further. They have to possibly fine you or worse. So when it comes to practices that have a lot of prescribing, it's not that it's no longer okay to do it, it's just that there are a lot of checks and balances and there are a lot of regulations around it that you need to make sure that you are, doing it correctly. Same thing with anti-kickback violations, New Jersey's Cody law, Stark, self-referrals. I have a lot of clients who think that they engaged in a completely legal agreement. It's an agreement that is standard for their practice, standard for the business. It's someone who came into their practice and said, "Hey, we have this same agreement with everyone," and then they find out that that same agreement with everyone violates New Jersey law. One of the ways it violates it is because you're contracting for services that are not allowed in the state of New Jersey. But in other states where that company does work, it may be completely legal. One of the main examples is probably in the last 18 months, allergy testing has been probably the biggest enforcement area, particularly with Horizon Blue Cross Blue Shield in New Jersey and Horizon NJ Health. We'll get into allergy testing a little more in the future, down the line in this presentation. But just so you know, this isn't a position that Horizon is taking. This is actually based on New Jersey regulations. The regulation is 13:35-6.4, which is the delegation of administration of subcutaneous and intramuscular injections and performance of venipuncture to certified medical assistants. Long story short, I'm not going to read you the entire section and bore you, but when it comes to allergy testing, including just the skin prick testing, preparation of allergens, maintenance shots, certified medical assistants cannot do them. Now, when we're talking about, document requests, what we're really talking about is investigations. No one requests documents from you. You don't get subpoenaed because of no reason. These entities, be it state or federal actors or the Board of Medical Examiners, they're all busy. They're all understaffed and overworked. So because of that, you're not going to get records subpoenaed that are not subject to some investigation. So a lot of times, when you hear investigation or document requests, they're kind of synonymous with one another. State investigators, they're the ones that conduct the board investigations. They may be working at the direction of a deputy attorney general, but you're really going to be dealing with state investigators. In other states, a lot of times they're older, they're retired police officers or retired detectives. In New Jersey, a lot of them are just career investigators, and you have a mixed bag. You have some that will come smiling at you just so they can get as much information from you as possible, and some will come in, like a bulldog. And I'll explain to you in a little bit how you should respond to both. You have to understand that when an investigator comes to you, a lot of times they'll serve a subpoena on you. A subpoena is a formal request for records. It does not mean that they have a right to interrogate, to conduct any follow-up investigation. It doesn't mean that they need the records on site that same day. A subpoena is just a document request that you have to comply with, but you can also challenge a subpoena. You can try to quash a subpoena. That's when an attorney goes to court and says, "Hey, Judge, this subpoena is either unreasonable or it's not directed to the right party or whatever other reason there may be." So the subpoena is a powerful document request. You have to comply with it, but you also have a reasonable amount of time to comply with the subpoena. You're never required to comply with it the same day. So because of that, don't go into the mistake, and have this happen to a lot of clients, that they said, well, they came in with a subpoena and they took all these records. A subpoena, you accept it, tell your staff, front desk people, okay, someone comes in, they have a subpoena, they want records. Okay, take a copy of the subpoena and let them know our attorneys will call you later today, or our office practice manager will call you later today. Someone will call you to coordinate the production of these records. And that's it. That is your duty to cooperate. State agencies like the Department of Health, they have more power. That's power that they get from the legislature. So they can come and do unannounced inspections. Again, just because they can inspect the premises, maybe because of their part of the VFC program, they want to make sure that you're keeping, VFC vaccines at a certain temperature, and that you're not intermingling it with your private stocks. They can come in, they can do that, but they can't interrogate, okay? And questioning and interrogating are completely different things. Similarly, federal agencies, a lot of times when we're talking about them, we mean most of the time the DEA. The DEA a lot of times will come along with a state investigator, and the reason they'll come with the state investigator is for, I'm sure no one's shocked, a prescribing issue. Usually you'll have a state investigator who will come to you with a consent order asking you to, or one of the physicians there, to surrender their ability to prescribe in New Jersey, so to surrender the CDS license. The DEA investigator, who is conducting a parallel investigation and is cooperating with the board, they will many times ask you to surrender your DEA license the same day. Never surrender your license that same day. That is the only bargaining power you have. If someone comes and says, here's a consent order from the State Board of Medical Examiners, sign it and sign this other form, which surrenders your CDS, and sign this other form that surrenders your DEA, and everything is over and you don't have to worry about a thing. First of all, investigators do not have the power to give you that assurance. Investigators will say whatever they have to say to get you to cooperate. That brings me to a lot of the common misconceptions that we see with our clients. First of all, investigators do not have a duty to tell you the truth. That is one of the biggest misconceptions. Well, the investigator told me that they're investigating other doctors, or they're investigating a patient and I was one of his doctors, and if I surrender my CDS, I can get it back at the end of the investigation. That's absolutely not true. Not only can they not promise you that, but that never happens. If you ever surrender your DEA license, the process to get it back takes usually no less than a year. And that's a year from when you start fighting for it. So don't take a DEA agent's, FBI agent, any kind of investigator's promises for the truth. They're trying to incentivize something. Again, with state investigators, they will try to abuse the power of the subpoena. Now, they may be allowed to have those records, but in a timely fashion, in an orderly fashion, so you make sure that you send them the full compliant records, okay? That's in their best interest, although they may want them today because they want to close out that part of their investigation and move on. Don't let them confuse the power of a subpoena with a warrant. A warrant is something completely different. In the case of a warrant, where someone comes in with a search warrant, look at the warrant. First of all, I would call an attorney. You don't want to deal with them directly if possible. But if you can't call an attorney or you can't reach your attorney, take that warrant. It'll tell you exactly where they can look and what they can look for. And that's it. That doesn't give them a power to interrogate. That doesn't give them a power to question. Everything that you say is voluntary. So the power of a subpoena is even less than the power of a warrant. A lot of times they'll say, well, if you don't come back, if you don't give us these records today, or if you don't give me a statement today, then I'll come back with police officers and we'll arrest you. Sometimes they may even come to your office with police officers. That's fine. They can't do that. It takes a week usually to get a warrant. So I don't ever feel like you have to do everything that same day just because someone has a consent order or a subpoena or other document request from the Board of Medical Examiners. It's something that's tricked, unfortunately, a lot of my clients, and just want you to know your rights. Another common misconception is that investigators only want a statement. They'll flat out tell you, hey, listen, I just want to know what's going on. I just have a couple of questions. Investigators are not interested in statements. If they were interested in statements, they'd ask you to maybe to write something, they'd prepare a statement, and then they would send it to you, and then you would look at it, revise it, sign it. That's how you really get a statement from somebody. They're not getting statements. They're trying to get confessions. They're trying to get admissions. And that's what they're looking for. And they will speak with you, and then they'll speak with your doctors, they'll speak with your staff, and they'll write down whatever they want in their report. And you have no way of knowing what they wrote down because they're not going to show you what they wrote. And then later on, your attorneys have to fight with them about whether you actually said this or not. So if an investigator says, I just want a statement, just say, we'll provide one through our attorneys. The last common misconception is that cooperation means future consideration. Again, the investigators don't have that power. It's usually the power is vested either in the AUSAs in the case of a federal investigation, the Deputy Attorney General's office in the case of maybe a civil or criminal justice investigation, and then the Board of Medical Examiners if it's a licensing action. Nowhere in there is their discretion from investigators. So investigators, again, they say things to you just so that they can get to whatever records you have or get a statement from you. Ends justify the means for them. That's all they care about. So to finish up this part of investigations and document requests, when is an investigation problematic? Pay attention to some things. When the investigator comes in, what tone do they have? Who's the investigator? How many agencies are present? If there are multiple agencies present, if the investigator is someone from a special investigation unit, if they're from the Board of Medical Examiners, if they come in, like a bull in a china shop, hey, I need this, this, and this, completely not caring about disrupting your practice, you should be on high alert. You should tell them, listen, we are willing to cooperate, but right now we have patients, and you can't come in here and disrupt this practice. You're disrupting these patients. You're disrupting the care we're providing. So what we're going to do is we are going to, have our attorneys call you later today, and we will sort out anything that you need. Thank you. Have a good day. And that's it. And if they still persist, then call your attorney, get them on the phone, and have them speak with them directly. Another way to determine if a document demand is really an investigation or something problematic is how specific versus how broad is it. If they're asking for, 20 things and all 20 of them relate to maybe a consulting or teaching or medical director position that you have with a company, you can bet that they're investigating that company and everyone who does business with them. If it's a broad one, hey, we just want 10 patients, and you don't see any connection between those 10 patients, nothing sticks out to you, maybe it's not as problematic. Also, the length of the document requests or the amount of records being requested in a subpoena is also indicative of how much they're targeting in on the practice. And also what type of records are being requested. Many times you can look at what's being requested and you can see, oh, every single one of these are allergy patients, or wow, look at that. They're asking for all patients who were referred to us by this doctor, or they all have to do with consultations, or they're asking questions about our, relationship with a particular lab company or DME company. When you see that pattern, make a note of it. And again, I would strongly suggest you get some sort of healthcare counsel involved to help you make the determination whether you have any exposure or not. So audits. Audits are the bane of everyone's existence, be it an audit from the IRS for your personal taxes, or if you're a practice and you're getting audited by one of the private payers or CMS. So generally speaking, everybody on this call knows what an audit's targeting. Basically, they're looking at what you build and comparing it to how you documented it. And they want to look at weaknesses in your coding and documentation. Now, all audits are not alike. Some are targeted, some are focusing on one issue, and some are looking to recoup money. Others are completely different. They're audits where basically it's part of your provider agreement, and maybe they want 5 or 6 charts. If they're looking for 5 or 6 charts just to do some maintenance and possible education, I'm not concerned about those. You shouldn't be concerned about those either. Where I get concerned is, well, how were you notified? Was it a letter? Did it sound nasty? Did it say that, who did it come from? Was it from a ZPIC auditor? A RAC auditor? What are some of the buzzwords? We'll talk about red flags soon. How many charts are being requested? Here's where the magic number is 50. If you're talking about 50 and up, that's typically enough for them to have a statistically valid random sample. Now, what does that mean? If you have a statistically valid random sample, that allows an insurance company to then extrapolate. That means that they can go back in New Jersey up to 6 years to extrapolate and claw back money that was paid up to 6 years ago. Now, I'm sure a lot of you know that New Jersey law prohibits recoupments beyond 18 months. However, that same very insurance-friendly law has 2 exceptions. One, where there is a clear instance or clear indication of fraud, which is tough for them to show. But 2 is this catch-all if there is a pattern of inappropriate billing. Now, a pattern of inappropriate billing is not defined by any case law. It's not defined by the statute where it's located, and it's not identified anywhere else or explained in any other statute. So what is a pattern of inappropriate billing? Well, if you do a little research, a lot of times a pattern of inappropriate billing can be as many, or I should say as little, as 5 instances where you build something the same way. Now think about it. As a medical practice, a lot of what you do is, I don't want to say standard or automated, but it follows a pattern. If you see a new patient, there are certain things you're going to do when you're seeing a new patient. If you see a lot of the same type of patient population, they're all either very sick or not very sick. You're doing a lot of consultations. You're doing, you're a specialist, so you do a lot of, audiology tests, whatever it may be. It is impossible not to fall into some sort of pattern of billing. By having the bar set so low, the pattern of inappropriate billing, if they can show that you were doing something improperly, they can go back up to 6 years. Now, most of the time they go back 5 years, but by having a statistically valid random sample, all they need to do is review maybe 50 to 100 dates of services for a 12-month period, find the error rate, let's say it's 50%, and then say, okay, well, we've paid you $1 million for this code or these sets of codes over the last 5 years. Your error rate is 50%, so you owe us $500,000. You can make the check payable to Horizon or whoever it may be, and we expect it within 60 days. Otherwise, we'll start manual reductions. And what is manual reductions? It means any money that you are owed for the work that you're doing now. Manual reductions means currently that they're taking back 50% of whatever you're going to be paid. And if you still don't agree to some sort of settlement or settlement plan with them or lump sum payment, then after certain months, it'll go to 100% recoupment. So you'll make no money from your patients until they collect that $500,000 or whatever that number is. That's where we get involved and fight back on that. So, red flags. When should you be worried? When should you, take action? If you see, that it's from a recovery audit contractor or a program integrity contractor, the RAC and ZPIC audits. Now, why is that an issue? It's an issue because those particular contractors are paid a percentage of what they recover. And because they're paid a percentage, lo and behold, they seem to find a lot of errors and are unwilling to compromise. It's the fault of RAC auditors and ZPIC auditors that the ALJ system was broken. ALJs were always understaffed, overworked, and had too many cases. But about 5-6 years ago, when RAC auditors started coming around and collecting ungodly amounts of money, and everyone started fighting the appeals, and they were getting denied for arbitrary and capricious reasons, really because the RAC auditors didn't want to give up money that they thought they earned. They wanted as much of a recovery as possible because they're percentage-based contractors. Everything went to an ALJ to be appealed. Now, when you go to the ALJ level, the third level appeal, you should have a decision, according to the statute, 60 days, within 60 days. Right now, the wait is probably around 2 years, probably even more. There are some CMS cases that I filed over 2 years ago that have yet to be heard. So that's how broken the ALJ system is. Some buzzwords to look out for: if they talk about billing irregularities, then that means they're targeting fraud. If they call you an outlier, then that means that they're going to go for a pattern of inappropriate billing. Again, large number of documents requested. It's because they want a statistically valid random sample. Also, I know that everyone on the call is from different types of practices, but look for specific procedures. This is where you can do a little bit of preventative care. If there are specific procedures that are reimbursed at a high amount, allergy testing, balloon procedures, a balloon sinuplasty for ENTs, consultations if you're a specialist, those are the most targeted area. They go after the big ticket items, and they also go after the most debatable, the ones that are more subjective. E&M office visits, such as, level 4 and level 5 office visits, level 4, level 5 consultations, hospital follow-ups. High-level E&M codes are subjective. You can sit 10 coders in a room and give them the same chart, and they'll code it, 5 different ways. There's no general consensus among coders, so they love to give their coders a lot of level 4s and 5s and deny 80% of them. Another thing to be wary of, which is a red flag, when they want to come to your office to copy records. Now, I understand that sometimes they may want to copy so many records that you don't want to be bothered, or you may be understaffed, or you don't want to spend, your time and money, copying records or taking people away from their regular, day-to-day job to just look for records and print them out or save them on a disk or a thumb drive. But when they're in your office, they start asking questions. And that is a pet peeve of mine, because if they're there just to get records, just to copy records, they should not be talking to the office staff, the office manager, to the doctors, asking them, well, when do you bill a modifier 25? Or do you know what the requirements are for billing a 99214? Or how detailed of a history do you usually take, doctor? Or all of these questions make it more difficult at the end of the day for you to settle this case, because they'll say, well, listen, you admitted to me, doctor, you don't know how to use modifier 25, so why should I believe, that you billed any of it correctly? Why should I give you any credit? Why should I not put you on prepayment audit for that code? There's a lot of things that they can do to you to be punitive. The way to avoid that is not giving statements. If you absolutely must let them in your office to copy records, don't leave them unsupervised in a back room. Don't give them unfettered access to your medical records. Get an MA or a staff member or somebody to print out records for them, because you also want to keep a copy for yourself. This comes to our do's and don'ts for most audits. So obviously you want to comply with it. If you don't comply, if you ignore it, bad things happen. If you ignore an audit from a private payer, they'll say, well, you didn't provide us any records, so we can't give you credit for any of the services. It's 100% error rate. So you're going to have to pay us 100% of what we paid you over the last 5 years. You don't want to get involved in that. Another thing you absolutely have to do is copy all the records, intakes, diagnostic testing, operative reports, everything that supports medical necessity, everything that supports the date of service at issue. You want to be over-inclusive, not under-inclusive. Again, don't give statements or hand over control of your workstation to an auditor. First of all, maybe Horizon's 60% of your business here in New Jersey. They're a massive company here in New Jersey. That doesn't give them the right to get onto your workstation, because your workstation has other people's, other payers, beneficiaries, other patients. They're not entitled to see those records. They're not entitled to snoop around. You don't want them snooping. You want them to get exactly what they're entitled to get in a way that is, reasonable, but also without giving away everything. I would say do not send illegible copies or sparse records, or fail to keep copies of what was produced. Your attorneys, your expert coders, whoever you're going to be working with, your billing company, they need to know exactly what was sent or what was copied. You need to have your own copy. If not, then you don't know if you're reading from the same sheet of music. You don't know if they're missing anything. Don't send illegible copies. We had a client once who really did not want to comply with his audit. So he decided a good thing to do was to send all of his records on red paper. Now, the issue with red paper is that you can't photocopy it. If you photocopy it, it comes out all black. He thought he was being funny and clever. Well, they gave him 100% denial, and then we had to basically work twice as hard to get him a good result. So again, there's no reason to, be antagonistic. You don't want to poke the bear. They're the ones who are going to be reviewing your records. They're the ones that we're going to be negotiating to try to either go away or take a lot less money than what they think they're entitled to. As far as trends in 2019, again, allergy testing, immunotherapy injections, that's the #1 issue, because there are a lot of companies, particularly some out of the state of Florida, who are sending sales rep or sending people, and they're saying, listen, we have MAs who are certified, who are specialists in allergy testing and immunotherapy. They can mix the allergens. We partner with, practices all over the state of New Jersey. We partner with practices all over the country. This is completely legal. Here's a contract, okay, that's great, but it's illegal. In New Jersey, a certified medical assistant cannot provide any allergy testing, regardless of their level of education or training in the area. The lowest level of licensure is an LPN, and that LPN has to have specific training in immunotherapy. That is the guidance given by the Board of Medical Examiners. If you're in pediatrics, developmental testing, that's CPT 96110, that's being audited a lot. A lot of people don't know that Horizon changed their policies back in September of last year, where now it's pre-authorization is required before you even do developmental testing. That is new. A lot of doctors didn't know that, because the notice given by Horizon of this, huge paradigm shifting change to a very frequently used code was buried as an asterisk on page 9 of a newsletter. The notice given was so inadequate that a lot of practices missed it, and we're fighting now to get them paid. So again, if you're in pediatrics, developmental testing, be careful of that. The Vaccines for Children program, which is administered by the New Jersey Department of Health, that can be hellish to deal with. So again, that's something that you have to make sure that you're keeping track of your lot numbers. You're not mixing private stock with VFC stock. High reimbursement procedures, again, ENTs, if you're doing balloon procedures, there's a litany of things that must be done before you actually do the balloon sinuplasty. That's across the board for basically every specialty, every type of surgery or surgical procedure where there's conservative treatment that needs to be exhausted. We're seeing a lot of the high reimbursement procedures being attacked, a lot of them based on medical necessity. And then, of course, you know, the oldies but goodies, the classics, they're constantly hitting on consultations, high-level E&M codes, and modifiers 25 and 59. Now, why do they hit on those? One, consultations, particularly when you're dealing with, you know, Horizon NJ Health and Horizon Blue Cross Blue Shield, they go above and beyond the CPT manual. So the CPT manual is very clear on when you can have a consultation versus when it's an initial office visit. Well, Horizon has taken it to another level, and they've added a number of different requirements before you can bill a consultation properly. Now, are they allowed to do that? Yes. Our issue is it's not clearly communicated to, you know, the doctors in their plans. So if you're doing a lot of consultations for Horizon Blue Cross Blue Shield and Horizon NJ Health, just be wary that their consultation requirements are very, very rigid and go beyond the CPT manual's black and white definition. Same thing with high-level E&Ms and modifier use. You know, they're, again, subjective codes, and believe it or not, auditors usually don't give doctors and practices the benefit of the doubt, which is, you know, where we come in. As far as another trend that is not on this slide, if you are a member of Horizon NJ Health, if you're, you know, if you have patients that have Horizon NJ Health as an insurance plan, be careful that they're not Horizon Blue Cross Blue Shield, and they're not New Jersey Medicaid. They're a managed care company. They, you know, their patients are Medicaid patients, and Horizon Blue Cross Blue Shield, you know, owns them or somehow affiliated with them, but they are neither Blue Cross Blue Shield nor Medicaid. And Horizon NJ Health has a very peculiar thing where they need every provider, every doctor of the practice, PAs, NPs, to be individually credentialed with them. So if you're credentialed with Blue Cross Blue Shield, Medicaid, but not NJ Health, once they find out about that, they will actually seek 100% recoupment for every service provided by those providers. We have tried to fight this many times, but this is something that is very unique to them. So if you do a lot of work with Horizon NJ Health, just please make sure your credentialing is in order. It's something that's difficult for them to find because, again, it's being billed usually under the MPI of either the practice or a doctor, you know, who is credentialed with Horizon NJ Health. That's why it's being paid. But when they take a closer look, because they're, you know, because of maybe they're auditing, you know, high-level E&M codes, and they start seeing the names of other providers on there, they start seeing signatures. That's one of the things that they're taught to look for. And once they see it, they can't unsee it, and it's very difficult to try to settle those cases. The last thing about audits, which I'll touch upon later, when audits are targeted, when audits are requesting a lot of medical records or high reimbursement procedures, when you see these red flags, it typically is going to lead to an overpayment demand. So that's why you want to have as little communication with the insurance company beyond just producing the records. Which brings us to our last part of the presentation, which is the nexus between all of this, overpayment demands. They do audits because they want to get paid. They're secondary usually to audits and document demands, these investigations we're talking about earlier. So they can be based on documentation, failure to credential services, or services being provided by an unauthorized provider, such as, you know, an MA doing allergy testing. So we talked about this before, the impact of on-site copying versus production. Again, On-site inspections expose the practice. I can't say this enough. You have to be very, very careful when you allow an investigator inside your practice. Is an overpayment demand looming? That's the number one question that I usually get. And this ties into the red flags we were talking about. How many documents were requested? Who's requesting the documents? Is there something related to a hot topic area like allergy testing? Or is the request general versus specific? Now, some common mistakes that we see with overpayment demands. First of all, you didn't keep a copy of what was sent out and copied. That's the same thing that we were talking about before with audits. You gave a statement without first speaking to an attorney. You produced incomplete or illegible records. You treated the request as something that was routine, or you didn't review what was being sent out. So when that happens, when you make those mistakes, it's not the end of the world. That happens to the best practices. That happens a lot because practices are busy. That's fine. It happens. We're talking here today so that hopefully you assign a person so that in your practice, be it the practice manager or someone that the practice manager thinks should is responsible enough, organized enough to deal with this, so that when audits come in, when document requests come in, if a subpoena is served on the practice, okay, that one point person will then take a look at it, figure out who, what, why. Do we need to escalate this? Do we need to get counsel involved? Do we need to, treat this as an emergency, or is this a routine request? So when you get that overpayment demand, how do you react to it? First and foremost, you have to fight every overpayment demand. You have to. And the reason for that is because you don't want to become just low-hanging fruit. If you become low-hanging fruit, then you actually end up being a target for future audits. If you make them fight for it, if you question it, if you make them give you an explanation, rationale, the investigators remember it. The auditors will never remember you because they don't know anything. They just review an individual patient records. But the investigators who are in charge of that, if they see that you're fighting them, if they see that you are active in improving any mistakes that were possibly made, engaging in a corrective action plan, they're not going to come back to you with a prepayment audit. They're not going to come back to you, 6 months later with the same type of audit, but for a different time period. These are things to take into consideration. So you have to fight every overpayment demand. This is particularly true even if the amount in controversy isn't a lot. I'm currently representing, a client who's asked me to help out on 2 issues, and it's just, it's just 2 dates of services. However, those dates of services are very important because on those dates of services, this provider actually prescribed a drug that the provider prescribes a lot for this one condition that the provider treats almost exclusively. So to have that sort of overpayment demand sort of, as precedent would be terrible for a practice because they need to know that she'll fight every time that overpayment demand comes in for that particular drug. Sometimes it might be a durable medical equipment that your practices use. It might be a particular service. It might be a particular drug. Whatever it is, if it's something that is done a lot, that would be impactful to have a bad decision, it goes beyond just the monetary amount. Now, one of the things that makes things, let me go back, one of the things that makes things a little easier for practices, but that a lot of practices are unaware of, is that you have most likely insurance coverage for this. That's one thing that, I've learned over the years, a lot of practices don't know. So your insurance company, your medical malpractice insurance company, a lot of times has something called an administrative rider. This administrative rider will pay for legal fees and expert costs. Now, if you owe any money as a result of the audit, you have to pay for it. There is no insurance policy that I am aware of to date that will pay for any reimbursements that were received incorrectly. So once you receive an overpayment demand, or even once you receive a audit or document request or subpoena that seems like it has some red flags, contact your medical malpractice insurance company or contact your broker, because it's very likely that you have coverage for it. And the good thing about that is that you will be assigned to an attorney, not necessarily me, not necessarily my firm, but you will be given the referral to an attorney that they'll pay for and the experts that they'll pay for that are healthcare specialists. And that's very important because healthcare is so highly regulated, you can't really dabble with the wrong type of experts, the wrong type of consultants, the wrong type of counsel. They all have to be experts in healthcare. Another thing to keep in mind is you don't give insurance auditors the benefit of the doubt. There's yet to be, a case other than non-credentialed providers because, that's obvious. But when we're talking about E&M codes, there's yet to be a case where we agree 100% with their code findings, where we agree with their medical necessity. That's where we usually disagree the most. We don't always agree with the statistical sampling. If the statistical sampling is not sound, then their extrapolation can be thrown out. That's the difference between owing $10,000 and $800,000. We never agree on the look-back period. We are very staunch in our position that an insurance company cannot go beyond 18 months, and usually they're staunch in the other position that they can go back 5 or 6 years. So don't give them the benefit of the doubt. Don't just take it lying down. Fight them on it. You may even have coverage for it through your insurance company, which means that you won't even have to pay for your attorneys and experts to go to war with them. So final thoughts on this. Again, you're all part of this the healthcare industry, which is one of the most highly regulated industries and full of pitfalls. I have a lot of clients that said, I wish I would have gone to law school if I knew how much I would have to know, how many regulations. It's not easy. We understand that, and that's why MGMA is here to help. That's why my firm's here to help. There's a lot of healthcare attorneys out there. There's a lot of coding experts, billing experts who are here to help and try to make your life a little easier. Sometimes handling a matter in-house can really be a lot more expensive than getting the right experts involved from the beginning, particularly if there's insurance coverage. You pay a lot of premiums, you pay a lot of money for them, use it when you need it. Take the time to determine if something is routine or if it's a potential red flag. And at the end of the day, there's no substitute for your common sense and your instincts. A lot of times I'll have clients say, you know what, I had a bad feeling when this investigator came along, or I just had, the wrong feeling, or, my common sense said this when I got this document demand. Trust it, okay? A lot of times if you think something is a little fishy, we can definitely help you investigate that. So if you have any questions or any Q&As right now, I'd be more than happy to answer them. If we don't have the time for it to answer all the questions now, we can do what we've done in the past where either Dawn or Bree or will send me just an email with all the questions that we weren't able to answer, and then I'll gladly respond to them in the next few days. So thank you very much for your time, and if you have any questions, I'm here to answer, even though we only have a few minutes.
Thank you, Guillermo. I'm going to read the questions now that we have from the question box in the order that they were received. If anyone has any additional questions, you may type them in now. So I'm going to start with the first one. And the first question was, will these slides be made available? And I can answer that for you. We are going to be sending all of the presentation slides to you following the completion of this webinar. And if anyone needs a CEU certificate, please just reach out to your staff MGMA email, and I will be happy to provide that for you. So the next question was, when DOH comes in, did you say that the records need to be pulled at the time that they come in?
No, the Department of Health can come in, and obviously it depends on whether they have a subpoena, whether they're conducting an investigation. Sometimes part of their investigation includes looking through some charts just to see, for instance, with the Department of Health, when they're doing a VFC inspection, they will look to make sure that patient charts have documented in there that they received certain disclosures about the vaccines. So in those instances, Department of Health, yes, you can let them look through some charts if it's part of their investigation. If they come in with a subpoena with 50 records, no, that you can tell them we will comply with this subpoena, but we need time, and you're not allowed to just come in and disrupt our practice.
Okay, the next question was, MAC carriers conduct targeted probe and education reviews. It is signed by a MAC clinical reviewer, not RAC. Do you consider these routine audits? If there was a moderate or major error rate, they educate and move to round 2 of a TPE review.
Yes, I'm actually, I do consider these potential, red flags. I've been a part of enough TPEs to tell you that if you have a high enough error rate, yes, you get educated, then you go to phase 2. If you have another, series of mistakes or a higher error rate, they'll escalate to phase 3. And once you start getting to phase 3, if you don't fix every single mistake and do a thorough, fantastic job, at that point, you're at risk of being terminated by CMS or facing a very large overpayment demand. So usually, we get retained. Sometimes insurance companies will assign us cases from phase 1. And what we like to do is, there's not much you can do at phase 1, obviously, because it's the initial one. But what I would say is, take a look at how you're doing. Phase 1, if you don't get an attorney involved right away, that's fine. But try to get someone involved if you go on to phase 2, because once you're starting at phase 2, there's more and more risk. At phase 1, you still have 2 more phases. At phase 2, I would not want to be, I would not be having an error rate that would have me go to the 3rd phase. I'd want to try to end it right there.
Okay, does waiting 2 years help or hurt your case?
Waiting 2 years help or hurt your case? Not sure in what sense that's being asked. I know that, from a litigation standpoint, it never helps to wait. Usually want something done quickly before people forget, before documents get lost or misplaced, before you lose witnesses. If you're talking about an ALJ waiting 2 years, again, it hurts in the sense that if they've recouped the money and you're trying to get that money back, you're going to wait years until you get your fair shake, until you get your money back that CMS maybe took. If you're talking about waiting 2 years for a just decision on a case that's very important to you, it doesn't hurt to wait. Maybe there's a development or a new regulation that comes out that makes everything moot. Sometimes CMS's attorneys will get involved. So I think it's more of a hindrance. I don't like having to wait 2 years. I think it hurts, but I understand how waiting can sometimes be beneficial.
Thank you. So the next question is, so in New Jersey, a certified MA with allergy testing training cannot perform allergy testing or give allergy injections under the supervision of a physician. The physician would always be present in the office.
That's correct. Even under direct supervision, they cannot be involved in that process. They cannot administer, mix, prepare, do subcutaneous injections, do skin prick testing. They cannot be involved in that process at all.
How do we know when Horizon changes their rules? Do they have any notices on their website or just a newsletter?
It's a great question. they should send you a notification. It could be by mail. A lot of times their notifications are sent out, I think in a blast email. They may be included in the newsletter, as we saw recently, although we're fighting back the legality of that, the appropriateness of that. And then lastly, on their website. That's where you see it most often. So periodically checking their website to see if they changed anything.
Does the allergy testing / immunotherapy injections done by MAs refer to every state or just New Jersey?
You know, at this point, I know it's New Jersey, but New Jersey is not the only state where MAs are not allowed to do allergy testing. Most of my practice is in New Jersey, so I know in New Jersey it's not allowed. I would have to check specifically what other states someone has a question about.
Allergy testing done by a CMA. Did you state that this is a state law?
Yes, it's a board regulation. So the Board of Medical Examiners, who has plenary power to enforce the practice of medicine, they're the ones given that power by the state legislature. They promulgate basically all the laws by which practices can practice, by which physicians can practice. And one of those is, like I mentioned before, and I can give you the exact regulation, it's 13:35-6.4, and it is paragraph D.
Okay. In regards to overpayment demands, our practice recently received an overpayment demand from over 7 years ago. Do we have to refund the money? They are claiming they paid wrong. Isn't there a statute of limitations for such requests? I am located in Maryland.
Maryland, that's a good question. I would have to look at the rules. Usually, unless it's an instance of fraud, in which case fraud can sometimes allow you to look back 7 years or 10 years if it's a federal case. But that seems excessive. I would definitely have to, have you consult with a Maryland healthcare attorney, because a 7-year look back seems excessive to me. Then again, it also depends on when the document demand was received. If you received the document demand maybe 3 years ago and just now they're getting to those results, I don't know if maybe then they have some sort of argument, but at this time, I don't think that 7 years is reasonable. But I would have you check with somebody who knows your local laws.
The next question is pretty similar. It says, how far back can insurance companies request recoupments due to their error? Example, coordination of benefits insurance paid as a primary and then realize they are not primary and request recoupment. How far back can they do this?
An error like that, where it's an error on their end, such as like paying a duplicative claim or something like that, that is 18 months. That's not a pattern of inappropriate billing. They just paid it wrong. So I don't think they should be able to go back beyond 18 months.
Do you deal with all prepayment audits?
Yes, they are unfortunately the bane of most practices' existence. I usually deal with those in conjunction with a certified professional coder. Certified professional coder will review claims, scrub them, make sure that nothing gets submitted that is not the correct code. If something needs to be downcoded, it gets downcoded. If documentation needs to be improved, that's communicated as well. Basically, yeah, that's the process we follow, and we try to get practices off prepayment review in 90 days.
Who is the we you work with during an audit?
A lot of times when I say we, I'm talking about working with certified professional coders. Depending on the audit, it might be a statistical expert if we're trying to attack the validity of an actual, extrapolation. It could be another doctor if we're talking about medical necessity, just to have an independent doctor. So the we is a team approach. It's experts and legal counsel.
Was this webinar mainly focused for the state of New Jersey laws?
There are some things that were New Jersey specific, but the general context is universal. I practice in I practice in New York, New Jersey, and Pennsylvania. I've handled audits in all 3 states. I've handled federal audits from CMS, and they're all basically the same in that regard. You know, common mistakes, do's and don'ts. As far as, you know, allergy testing and things like that, those were more New Jersey specific, but I would say 85 to 90% of the slides and presentation had general applicability.
If we have overpayments from more than 18 months ago in regards to the coordination of benefits, do we have to refund or notify insurance of their error?
I would think you'd probably have to notify the insurance company of the error.
Would you recommend doing some type of external chart audit to get an idea as to where we stand? If so, should we have an attorney oversee it?
Yes and yes. The first part, you definitely want to know what your potential problem areas are, your areas of risk. The second part, I stress oversight, not necessarily to do it. You know, you should have a certified professional coder that the attorney can help you with. I know that I would deal with a number of them, so depending on what specialty the practice has, I might use a different coder who's a specialist in that area. And then basically I would just coordinate so that the expert takes a look at the records. I'm involved for confidentiality reasons, and then, you know, any corrective action plan is outlined.
Can you talk a little bit about prepayment audits from insurance companies? What if they are requesting notes on every claim submitted?
So prepayment audits, they're supposed to only ask for specific codes. You know, they can't just say, hey, every patient that you have in the practice, send me their records. That's unreasonable. That's something where I would, you know, contact their legal counsel, maybe even contact the New Jersey Department of Banking and Insurance, DOBI. That's absolutely something that should not be allowed. Usually they're looking for, you know, you'll get a letter that says we want every level 3, level 4 E&M code, or every modifier 25. Now, if most of your practice gets billed at level 3, level 4, that could mean it's most of your practice. But the prepayment audit, you can't bill without sending in the records. You have to send them in pretty much around the same time. And, you know, it's a true pain because, you know, it really affects your cash flow. And if you don't have a passing rate of at least, I believe, 80% every month for 3 consecutive months, so you can have 2 good ones and you fail one, you have to start all over again. You have to get a passing rate for 3 consecutive months before you're allowed to get off prepayment review.
Can you please touch on the immunotherapy injections again?
I'm not sure exactly in what sense. I can tell you that immunotherapy is right now the most highly audited area for primary practices, pediatricians, and anyone who really is not an allergist. They're focused mainly on the issue that, you know, 1, are MAs doing it, and 2, if MAs are not doing it and a doctor's doing it, is it medically necessary? And is it medically necessary means 2 things. 1 was what was done, and 2, why was it done? Or in the, you know, inverse. So why was it done? Why were you testing this patient for allergy? Okay. And second, if it came up that there was an allergic reaction, okay, what did you do? Did you treat the patient? Did you refer them out to, you know, an allergist? If you're just testing a patient and then not following up with any treatment or referrals, that's going to be a red flag, and they're going to say that you were doing a medically unnecessary service.
Where can I find the 1335-6.4 regulation?
It's on the Board of Medical Examiners website. You can actually probably just Google it, New Jersey regulation, and then put in that number, and it'll come up.
All right, and the last question is something I can answer. It says, can you tell us again what email address we need to write to in order to request CEO certificates? So you will be able to go on your state MGMA website where you registered for the webinar, and there should be an email, whether it's staff@Maine MGMA, staff@Vermont MGMA, and just email us and we'll provide you that CEU certificate. And we just had one more question come in. It says, when in prepayment review can you ask your passing rate by month?
You can ask it basically anytime. And you should, usually they try to give you a report card that's a 90-day report card, but I try to get them every month. If you started on the 15th of a month, by the 15th of the next month, ask for it, and they should give it to you within a week.
Okay, thank you, Guillermo. If there are no further questions for the day, then we can wrap this up. Once again, the presentation slides will be emailed to all participants and will be available on our website for members only. If you have any additional questions, please reach out to the presenter directly, and thank you everyone for attending. Have a great day. Thank you.
Thank you.